I'm Lynn Madden. I am the CEO of the APT Foundation. I've been here at APT in New Haven for about 16 years. And it's my pleasure to talk with you today in the company of the director of our Access Center, Scott Farnham. So we're going to talk today a little bit about how to ask for what you need to treat a substance use disorder. And we're going to drill down particularly on opioid use disorder. But a lot of the things that we'll be talking about are related to the treatment of any substance use disorder. And I'm going to turn the floor over to Scott we're just going to start at the beginning and think through really what is a substance use disorder.
So generally speaking, not generally, substance use disorders are all considered to be mental health disorders, and the same as depression or anxiety would be, and they're considered that way by the treatment community. And basically what a substance use disorder is as it says up there, that a person loses their ability to control their use of substances, such as legal or illegal drugs or medications. And the severity of that disorder ranges from mild to severe, depending on how many symptoms of the disorder you exhibit. So every substance has a fair amount of overlapping symptoms, but they also all have their own unique profiles. And today, the one that we're going to look at in depth is the opioid use disorder, or what we call OUD. So in order to get a diagnosis of mild opioid use disorder, you have to exhibit 2 to 3 of the symptoms that are present in what's called the Diagnostic Statistical Manual 5, which is DSM-5. That's sort of the Bible of the psychological world in terms of deciding what kind of mental health problems you might be exhibiting. And the reason there's a range on the symptoms from 2 to 3 is some of the symptoms are more serious than others. So it's possible that you might have 2 really small symptoms, and maybe we really wouldn't diagnose you as being opioid use disordered, but they might be 2 really serious symptoms. So you'd make the mild level by having that number. So then, as you can see, it goes up to 4 to 5. And then anything beyond 6 would be considered severe. So 4 to 5 is moderate and severe is 6. So this is just actually kind of a short list of the common substance use disorders that are covered. There are others, but so this is not exhaustive. But what you can notice here is that some of these substances are legal and part of our everyday life. Others are legal, but then they are used illegally, or that would be opioids in particular, that many of them that are used by people who have a substance use disorder are actually legal substances that have a legitimate medical use, but that are used in a way that is illegal. And then you have kind of a mixture where you have like cannabis, which is legal some places, not legal others. So it kind of covers the range of things that are possible. So what are opioids? I don't want to get too far out into the weeds on this, but there are some misunderstandings, I think, by people about what opioids really are. So back in the day, everything was considered to be an opiate, but that's actually not accurate description. That's why we've gone to opioids. So opioids actually cover a range of 3 different kinds of substances. So there are natural opioids, and those are ones that are derived almost entirely from like the opium that comes out of a poppy. And that would be like morphine. Heroin is in that category. But then there are what are called semi-synthetic opioids. And they are where you take the naturally occurring substances and you engineer them in a way that gives you effects that you want them to have, targeting particular parts of your body or particular receptor sites. And in this category are things like OxyContin. That's probably the one that people would really know. It's got natural opiates in it, but it's also a semi-synthetic compound as well. And then you have opioids, which are totally synthetic substances. They don't have any of the natural morphine-like substance that comes out of an opium poppy in them. And that includes things like methadone and actually buprenorphine, which is one of the substances that we use for treatment purposes, and methadone as well, are both synthetic opioids. They don't have natural morphine in them, although they do produce morphine-like effects. That's what they're designed to do. Medically, they're primarily used for pain relief. There are other conditions that people take opioids for, intestinal disorders, things like that. But the overwhelming majority of medically accepted practices for use of opioids are for pain relief or anesthesia as well. So what is an opioid use disorder, OUD? It boils down to that they're problematic patterns of use that lead to significant distress or impairment by the person who's using them. It almost always includes prolonged self-administration of the substance, not being used for a legitimate medical purpose, or if they often are, some of the time people start out using opioids for a legitimate medical purpose, and it gets out of control for them. They start using it in excessive amounts beyond what would be needed normally to treat the medical condition that they have. So as I talked about initially, the number of symptoms that you have determines the severity of the disorder. So these are the common symptoms that are listed for diagnosing someone with an opioid use disorder. And I'll just run down through them very quickly here. So taking larger or more frequent amounts of opioids than intended. So person, basically they lose their ability to control the amount and the frequency with which they're using the substance. They exhibit a persistent or experience really a persistent desire, or they try unsuccessfully to cut down or stop using opioids on their own. So that would be another symptom of somebody who's suffering from an opioid use disorder. They spend exorbitant amounts of time obtaining, using, or recovering from the effects of opioids. That includes things like getting enough money in order to buy them, finding somebody who can supply them to you, and then spending some time where you're not well enough to really engage in everyday activity because you're recovering from having used them, or you're in a current state of intoxication from them. Craving is probably the one that most commonly people experience. They have an unrelenting desire to use. It's really very, very intense. It's not just like, I'd like a ham sandwich. It's like they really are focused on this, and it consumes a big part of their life, the desire to use. They start to fail to fulfill life obligations. In other words, they don't show up at work, they don't show up at school, they don't show up at family occasions. They just basically stop being able to take care of what would be normal day-to-day activity. They continue to use despite these negative social or interpersonal consequences, and they give up or reduce important social, occupational, or recreational activities. So it's not just having negative consequences, it's also just giving up doing any of these things at all. They also, there's one of the symptoms would be that you use in situations where it's physically hazardous for you. You know, that would include things like being so anxious to use. Would be a common way this would play out. Actually, you go and you buy the substance that you're going to use, and you don't wait to get home to use it. You go into an alleyway, or you go into a public bathroom, or you go somewhere that really poses a hazardous situation for you, and you use there because you just can't wait to get to where you might be safer in a lot of situations. You continue to use despite negative psychological or physiological consequences. And this is something that the person would recognize. Like they know that what they're doing is causing them physical problems, or it's causing them psychological, emotional problems. And then the last one on the list is increasing tolerance. So the more frequently you use an opioid, the more tolerant you become to the effect, meaning that you have to use more and you have to use more often in order to get the same effect that you were getting before, or you reach the point where you're having to use significant amounts of the opioid just so that you're not sick from withdrawal syndromes. So how do we treat opioid use disorder? Well, these are the 3 FDA-approved medications currently. There are different formulations of these medications, but I'm not going to go into all of the different formulations. But the 3 basic substances that are currently approved by the FDA for opioid use disorder is methadone, which is a total, what they call a total agonist, a complete agonist, meaning that it will go and attach to receptor sites for opioids in your brain and the rest of your body, and actually perform the same action that other opioids will, and there's no limit to how much of that substance you can take and continue to achieve increasing effect. Buprenorphine, on the other hand, is what they call a partial agonist. It does create some of the same properties that other opioids do, but it has what's called a ceiling effect. So once you take a certain amount of it, you get the maximum effect you're going to get, and you can't get any more. And why that's important is some people can't actually utilize buprenorphine as effectively in treatment for OUD because they get to the top ceiling effect of the drug, and it hasn't controlled all their symptoms. Whereas methadone can be increased to a point where it does control those symptoms. Naltrexone is a really different approach to using medications. It's what's called a total antagonist, meaning it goes into, when you take it, it goes onto the receptor sites that are stimulated by opioids, attaches to them very strongly, and prevents them from being able to be stimulated by opioids. So in effect, it's a blocker. It's a blocking effect of the opioid.
Scott's drilled down quite a lot on opioid-related symptoms. One of the reasons that we're concentrating on this today is that the opioid-related fatalities or deaths, it continues to climb in the United States, and as well as here in the state of Connecticut and in the city of New Haven, which is where we are located. In 2020, which is the last full year where data has been well analyzed, the final death toll from opioid-related overdoses was more than 90,000 people. This is a significant number of people. And without dramatic policy and public health interventions, this number is estimated to possibly be in excess of 125,000 persons a year by 2025, which is 3 years from now. And interestingly, and I think importantly, for every fatal overdose, there are 30 non-fatal overdose events. So when we talk about, how do you advocate for yourself or for somebody else that you may care about or someone that you know to really navigate into treatment or into a less harmful use of drugs, it's really important to have information. So every time there is a fatal overdose, we know that 30 other people, and this number holds up really well in all kinds of different research, 30 other people have had a non-fatal event. There is some research that suggests that non-fatal overdose events may be an opportunity to help a person think differently about their use, perhaps maybe navigate into treatment or start to use other harm reduction kinds of approaches. So what do we want to know about accessing care, right? So if we're thinking about self-management or the person or who has opioid use disorder or any other substance use disorder, if we go to the next slide, what we can see is that real-time motivation to reduce or stop using is an ideal time to reach out for care or support. Now, sometimes it can be as much as a phone call to somebody that you care about and say, I really would like to stop using, or that scared me, or I don't want this to happen to me anymore, right? So one of the challenges that we have is that treatment is not always readily accessible. For a person who's using drugs or alcohol, motivation can be really difficult to hold on to. So when we say it's important to capitalize on that real-time motivation, give the person something in real time, that's because part of what happens to people's motivation when they use is negatively impacted by drug or alcohol use. So you might say in one moment, I'd really like to stop using, but if it takes 3 weeks for you to get into treatment or to reach out to somebody, often that motivation is lost at that point, right? So it's a really important, I think, fact to understand that motivation is affected by drug and alcohol use. So we all know people who have reached out to someone for help and then seemingly changed their minds. Well, it's not so much that they change their minds, it's that they can't necessarily hold on to that motivation long enough to actually navigate into treatment. So why don't people seek care or support? Well, the research is clear that the key reasons that people don't enter treatment, and people have their own reasons, but the key reasons that people don't enter treatment or seek support are these. They're ashamed of themselves. It's very difficult in our culture to call yourself a problem drug or alcohol user, right? Using opioids is way down the list. It's much easier, even though it's still shameful to admit that you have an alcohol use problem than it is to say that you have an opioid use problem, right? Because it's more stigmatized. That goes back to something that Scott was saying around the fact that some drugs are legal and some are not. Alcohol and tobacco are legal, and so people use them very openly, and it is, more culturally. It's more culturally favorable to admit that you are having difficulty with tobacco or alcohol than it certainly is for other drugs, and particularly for opioids. It's not only shameful for some people, it's stigmatizing, right? So maybe you can't get hired anymore because you tell the company that you work for does drug testing, and perhaps you're taking a medication for an opioid use disorder. So not only does the person experience shame and stigma themselves, the treatments are also stigmatizing, right? These evidence-based treatments using medicines for opioid use disorder, which is the only evidence-based treatment that really exists with any robust outcomes for opioid use disorder, is highly stigmatized, right? So it's kind of a vicious cycle. So when we talk about, how do we help each other navigate navigate substance use disorders, part of it is really being supportive of a person, right? Listening to them, helping them reach out if in fact they're ready to do so. You can offer somebody a ride. You can say, I know APT Foundation or other places perhaps will take you tomorrow. So there are lots of ways of working against stigma, but one of those ways is to really understand that some of the behaviors that are being exhibited by the individual are really due to their drug use disorder. So another key reason that people don't enter treatment is wait time, right? So you heard Scott talk a bit about the compulsive nature of using drugs and alcohol that defines whether you have a disorder or not. So rhetorically, what do we think actually happens for people who have to wait? If they call or try to navigate the healthcare system and they're told we can get you in a month, which is the average wait time to medications for opioid use disorder across the United States, it's very likely that the person isn't able to wait a month. So there's a couple of things happening there. One of them is that the message they're being given is that it's not an emergency, right? If you can wait a month to have something treated, then it's usually not considered to be an emergency. And that message gets internalized by the person who perhaps is reaching out for help as well. Another reason people don't enter treatment or seek support is they can't afford it. They don't think they have resources. There are organizations that will treat people who can't pay, or some people don't want to stop using yet, right? They're not ready to stop using yet. So if we think about how to advocate for ourselves or someone that we know, I think it's really important when we're talking about kind of navigating against the stigma issues and more into thinking about these substance use disorders as chronic illnesses. It's important to keep in mind that treatment actually works. Social support and family support matter, right? So instead of holding people who admit that they use drugs or alcohol in lower esteem in our culture, we need to think about ways of thinking about these issues more like other chronic illnesses, like diabetes, for example, or chronic obstructive pulmonary disorders. Those too are illnesses or that can be very much influenced by a person's behavior, just like a drug or alcohol use disorder can. But in fact, we're supportive of people who develop these illnesses. So social support and family support really matter. Think about substance use disorders as chronic illnesses. And one of the things that's important when you think about any of these things as chronic illnesses is that it's really common that people enter care multiple times before they achieve a one-year period of non-use. So when we think about advocacy from a research point of view, all of these points that I'm making here, that we are making here, really are well supported by the literature, but they haven't really made it, some of them, very far into our cultural norms. There are many ways to reduce the harms of drug use, including preventing overdose from drugs. Narcan is effective and available, and it saves lives. We have done some Narcan training, and we can, in fact, attach a link to Narcan training, and we'll provide Narcan as an organization to anyone who wants to view the link and come in and pick it up. Be evaluated. If you're worried that you have a substance use disorder, as Scott said, they range from mild to severe, right? It's a good thing to get evaluated. Know what you're up against, or encourage people you know to be evaluated. Being evaluated is just a way of getting information about what's going on for you, right? And then there's a plan post-evaluation, but evaluation can be a very useful tool for a person to see where they are in terms of the severity of any substance use disorder that they might actually have. If you are evaluated, or a person that you know wants to be evaluated, ask questions, right? What's the treatment look like at the place that you're being evaluated? What are your options? What can you do today? What can you expect from the treatment, right? If you're prescribed a medicine, the medicines that Scott described for opioid use disorder, take an adequate dose. So this is a really interesting thing that's coming out of the literature. There's kind of a set of cultural ideas that if you are using buprenorphine or methadone as part of your recovery from opioid use disorder, the less you use means that you have less acuity in your illness. And that's not really true, right? The less you use, if you use a dose of medication that's not adequate to treat your illness, then in fact, you don't feel very well. So you're more likely to relapse, and then you're more likely to believe that the medicine doesn't really work for you. So you really have to take an adequate dose of the medication. So a lot of times we hear from our patients that family members or other significant others in their lives are encouraging them to stop using the medicine, or to taper the medicine, or to take less of the medicine. And this is very analogous to, I think, to antibiotics, right? If you don't take enough of an antibiotic, or you don't take it long enough, it doesn't really work for you. And then in the end, you get the infection back, but it's even worse. So if you're underdosing on your medicine for opioid use disorder and you stop using it as a result, or you have breakthrough use as a result because you don't feel very well, those harms, that your baseline level of risk goes right back to where it was before you were using. If a person returns to drug use, in other words, has a relapse, re-enter treatment as quickly as possible. This is not a treatment failure. This is normal part of recovery for a person with a chronic illness. They need to enter multiple times before they feel good about what they're doing and before they achieve a 1-year period of non-use. So I wanted to share really quickly with you a couple of pieces of research. Prescribing decisions at buprenorphine treatment initiation. So we were just talking about taking an adequate dose. And what this is Angelica Meinhofer and colleagues, this is from 2020, and this is about buprenorphine, which can be prescribed in multiple treatment settings and is starting to be more widely prescribed across the United States, despite the fact that it's been available since the early 2000s. Buprenorphine hasn't been widely prescribed until the last couple of years, and we still have some parts in our country where it's difficult to be prescribed with buprenorphine. What we found in this particular study, what she and her colleagues found, is that the lower initial dose is associated with the increased likelihood of dropping out of treatment. Right? The other thing that's associated with the increased likelihood of dropping out of treatment is not getting very many days of the medicine. So if you're only prescribed a day or two of the medicine at too low a dose, right, or even a week or less of the medicine at too low a dose, means you're less likely to continue. And interestingly, if we go to the next slide, so this is a different cohort study out of China. And what this team found is that persistent cycling in and out of treatment is common, but insufficient dose and and using at the beginning of treatment are predictors of subsequent dropout and re-enrollment. So interventions should target clients in the early stage of treatment. Be nice to people when they walk in the door, right? Go with your friend if you have one. Be a supportive person. It's hard to admit that you have a drug use disorder, right? So smooth that pathway. Make sure the person asks questions. The other thing that we can see about dose, and this is a paper authored by Scott and a team that we work with in the country of Ukraine, we also see here that higher doses of opioid agonist therapies, or methadone or buprenorphine, in other words, appear to be associated with higher levels of treatment retention. This is for the entire country of Ukraine, right? So we can see this literature is all over the world. You can see from every part of the world that getting onto a medicine quickly in a way that is reinforcing for you, in other words, you're taking enough of the medication, the people there were nice to you, is a predictor of staying in treatment. And it's also a predictor of re-entering treatment. So as I said, most people end up dropping out at least a time or two. The average number is somewhere between 5 and 7, right? It's just like trying to quit smoking. Most people try multiple times to quit before they're successful. But if you drop out and you've had a positive experience of the medication at an earlier treatment episode, you are much more likely to re-enter. So that's the other reason for not low dosing people, right? Because it doesn't reinforce them. They don't feel that well, and they start to believe that the medicine doesn't really work for them, which means they're not very likely to choose that as a treatment option down the road. The length of time in treatment or opioid agonist therapy is really important. So this is the other kind of cultural consideration that we have. There is a real set of ideas out in our culture about the fact that you're not altogether better until you're not using any medication at all for your opioid use disorder. And this is not a valid argument. Again, from a research perspective, what we see is that if you stay in your treatment with a medicine for opioid use disorder for 3 years, about 50% of people who do that are able to be free from any other opioid use for 12 months. If you can stay in for 5 years, right? So we encourage people to keep taking this medicine, it works for you, then about 75% of people gain a period of non-opioid use, a 12-month period of non-opioid use. 10 years, 90%, but only 10% of our persons who start medicine for an opioid use disorder actually stay in for 5 or more years. And there are a lot of reasons for that, but some of the reasons really have to do with I think pressure, community pressure, family pressure, maybe pressure from the workplace to stop using the medication, right? So we have to think differently. We have to think about these as chronic illnesses and not stop using medicines that are actually working for us. So what do we know in summary from the literature, from research? What we know is that rapid treatment entry, particularly within 72 hours, so really capitalizing on motivation, whatever happened, perhaps it was an overdose event, perhaps the person was just fed up, really helping people capitalize on their motivation. Go on a website with them, fill out a form somewhere, see if you can try to make an appointment, even if it's in the middle of the night, right? That there are things that you can do as a using person or as a person who is associated with persons who use that can help them stay motivated long enough to actually try and navigate the entry point of treatment. That has to happen within 72 hours. Same day access to medication is best case scenario for opioid use disorder. There are also medications for alcohol use disorder that are not widely prescribed that have some efficacy. Treatment entry for opioid use disorder with a medicine is associated with decreased all-cause mortality. So it decreases death from any cause and with reduced death from overdose, even if the person doesn't stay in for a long time. So as we said, entering treatment one time and having a good experience is the best predictor of entering again. Most people have to enter multiple times in order to do well over time. But treatment entry itself, even if you don't stay a long time, particularly at the beginning, is associated with lower all-cause mortality and reduction in overdose deaths. That's because some of the things that people learn when they're in treatment help them take care of themselves and other people around them. Higher doses of the medicine are associated with higher patient retention and decreased opioid consumption. And then adequate doses of the medicine are those that suppress the symptoms of withdrawal, reduce opioid craving, has adequate blockade, and no opioid excess symptoms such as falling asleep and nodding out. So when you think about trying to find resources, we put a few things up here for you. The federal government, SAMHSA, has a great treatment locator. The state of Connecticut has a treatment locator through our Department of Mental Health and Addiction Services. There are harm reduction services all around us, including the community healthcare van run these days by Yale University. And of course, we here at the APT Foundation are online and we would love to see you or anyone that you know. So just walk in. Access Center is open Monday through Friday, 8 to 11. You might see Scott there. It's at 1 Long Wharf Drive in New Haven. Here's our telephone number as well, and our website. And I'm happy to let you know that we are in the process of being able to offer walk-in evaluations 7 days a week. We were recently funded by the Department of Mental Health and Addiction Services to offer walk-in services 7 days a week, and hoping to get that up and running in the next couple of months. So I think everybody is welcome here. Really want to highlight that. If a person you know has no ability to pay for treatment, they are still welcome to come here. We will do a full evaluation. We will make recommendations and help them navigate their way into care. So with that, I think we'll open it to questions or comments.
So Lynn, hi, we did get the link up for the overdose prevention training with the note that Narcan kits are available at the APT Foundation main clinic at 1 Long Wharf Drive for anyone who've used the training and wants to be prepared. We've posted the resource guide for family and friends, and I am dropping in the resources for self-care. Can you talk a little bit about why the APT Foundation decided to develop those resource guides and what information it contains that people might not find at
Yeah, absolutely. Yeah, we have Scott and I have worked together for a long time, and as well as other team members here from APT, and we've become increasingly convinced that people who have substance use disorders have some skills to manage themselves, right? They really can manage themselves. And I think the pandemic was a really interesting natural experiment in this, where we, by the order of the federal government, we were able to give people more take-home medicine than they previously were allowed to be prescribed, both methadone and in the case of buprenorphine, they didn't have to come in as often as they did before. What we learned is that our patients did really, really well, even though in some cases they had a lot more take-home medicine than they did before the pandemic, because we, of course, have to follow the regulations. So that really, I think, reinforced some ideas that we'd already been developing about self-management, right? If you give people options, all of which are relatively healthy, you can come here, you can choose, if you will, the kind of group that you want to go to. You can talk with us about which kind of medicine you might like to take if you're a good candidate for a medicine, right? We are really thinking differently. And that's, again, been something that's been developed really over about a decade and a half of work, is really thinking about the person as not a patient, but rather a person who wants to work toward a goal of being better than they are now. But that doesn't necessarily mean that they're all the way to the point of complete sobriety.
And I think it really helped us understand the role that stigma was playing in terms of people exiting out of treatment earlier than they ought to be. And how we came to that thought was when we were able to increase the amount of medication that people were managing at home, it became more like other medicines that they took. So methadone and buprenorphine are very restrictive in terms of the laws that existed prior to COVID about how much you were allowed to have in your possession and manage yourself. And we got lots of feedback from patients that when they were getting 27 days worth of medicine at one time, it was more like other medicines that they took, and they felt more normal and less stigmatized than if they had to come in every day or every 7 days. There's no other medicine where you only get a 7-day supply and have to keep going back to the doctor every 7 days in order to get another 7-day prescription. So it was very enlightening that way. And there's lots of programs around the country who also were able to do this. And the data is starting to come in that this had a really, really positive effect on treatment retention. And with very few adverse downsides to doing it this way.
That is so interesting. What do you think some of the main questions are that people tend to have when they hear about open access and how you all are encouraging self-management? I mean, what do you think challenges people about it, and what questions do they usually have?
Yeah, that's a good question, Eleanor. So a couple of questions. One is, there has been a traditional set of ideas that has surrounded the substance use or addiction treatment field for a long time. One of them being that a person, if a person relapses to drug use, then perhaps they're not ready to be in treatment, right? What we've learned is that almost everyone relapses to drug use. So this question that we get, and most of them, if they're well treated, they will return to treatment, right? So that's much more common than coming into treatment one time and just one and done, right? So that certainly informs some of our decision making at the APT Foundation. So if you test positive for a drug of abuse, if it's really dangerous, if you're co-using drugs that shouldn't be used together, we will have a conversation with you. We might make a change in your care plan, but it is not a cause for being discharged from care, right? So it used to be common that people who relapsed to drug use while they were in treatment were asked to leave treatment and come back when they're ready. So we don't do that at APT Foundation. Using drugs is a symptom of a drug use disorder, and we treat that information in a clinical way. We also try really hard to help ourselves and our patients continuously understand that tomorrow is another day. Yes, you may have relapsed, but here you are. So glad you came back today. let's just try to get you to tomorrow, right? Tomorrow's another day. And so we've really shifted, I think, our thinking about who the person that we call patient is, and try to reduce program level demands on that person. The more demands you put on someone, come this time every day for this many days, bring these pieces of paper, show up with this card, don't be late. The more demands you put on a person, the less likely they are to be able to navigate those demands. So we just systematically have looked at our treatment programs and tried to reduce demands, to make it easy for people to enter treatment and easy for them to be encouraged to stay in care.
One of the things that we started to ask ourselves is, could I do what I'm asking this person to do if I was receiving this treatment, right? And if the answer was, I would have real trouble doing what I'm asking this person to do, we stopped doing it, because it didn't make sense to put demands like Linda's suggesting on people that I couldn't do. You know, I take medicines for different things. I could not do what we were asking some of our people to do and continue to take that medicine.
You make a really good point. So there's logistical barriers, but also these perceptual barriers, and you've been working on both of them.
Yes.
Parallel. When people hear clinic and they know it's a place where you can go to get maybe medication for treatment, what else happens there? Can you just kind of give us a snapshot of the inside and of a clinic?
I can see Caleb smiling. We do, that foundation provides a lot of other services. So we do provide medications for opioid use disorder. We also have a drop-in group menu, so people can choose the groups that they want to go to, right? And some of those groups are run by our vocational services team. You can also use vocational services at APT Foundation without being a patient or having a diagnosis necessarily that we're treating you for here, right? So we have vocational treatment. We have primary care services, which can be accessed at your local clinic. So we have a regular schedule of our primary care team who go from clinic to clinic and are available to give you an immunization, a flu shot, a COVID shot, a COVID vaccine shot. We have residential treatment services as well. And the groups themselves, I think, they're really interesting. We try to keep them interesting. So they might vary from journaling, for example, or art therapy, to a group focused on men's trauma or women's trauma. We offer parenting classes. So there's a whole range of services the way that we developed that menu, if you will, is by looking at what groups people actually come to, right? So if we list it, if we have a list, and we do have it on our website, it's a menu. You can tell what time the group is going to be offered, who will be running the group, and where it's going to be, and you can go to that group. And if no one goes to a particular kind of group that we run, then we put our heads back together and we say, well, let's think about this. What else could we do that might be interesting to people? We also ask our patients. We do a lot of pre and post surveying on a regular basis to see what they took from the group or the encounter that they had in the organization, and what else they might like to do here.
This is a question, I think, probably for Scott. Does opioid use disorder carry with it the assumption that you're going to be at risk or contain kind of other addictions, quote unquote, gambling, other kinds of things that people might have a problem with?
I'm not sure I understand exactly what you're asking.
Does having opioid, maybe Lynn can ask him more direct, does having opioid use disorder make it automatic or highly likely that you would be addicted to other things too, or behaviors?
You might not reach a level with other behaviors or other substances that would give you a diagnosis of substance use disorder or like gambling disorder. But yes, it's very uncommon actually that somebody only uses one drug and no others. That would be a rare patient that only used opioids. They almost always are engaging in other kinds of substance use behaviors or compulsive behaviors that are kind of a whole with the compulsivity that goes along with the opioid use disorder. So yeah, it's rarely that specific, that somebody only uses one thing and nothing else, or only engages in one set of compulsive behaviors and no others. So yeah, I mean, in fact, you really need to ask those questions of people who come in for treatment, because it's easy to focus on the fact that the person shows up and they say, I want treatment for opioid use disorder. And they give you information that would indicate that, yes, that's an appropriate course of treatment. You really need to expand your questioning, because the other behaviors and the other substance uses do impact their ability to get a handle on their opioid use. So that's a really important thing to keep in mind, that these are rarely singular disorders. They're almost always polysubstance use disorders. The other thing about that I would add too is that because of the highly illegal nature of opioids, there are times when a person can't get opioids very easily. So that also leads them to use other substances because they're trying to feel better, right? Because they start to go into withdrawal quite rapidly. And you do get some relief from the symptoms. Like, for instance, if you drink heavily, and when you can't get opioids, you will feel a little bit better, but then you have a problem with the alcohol. So they play off each other a lot that way.
From the friends and family point of view, what advice do you have for people to be supportive? You talk about the importance of family support. Does your advice tend to seem counterintuitive to people, or is it actually more intuitive in some ways and different from what they may hear other places?
Mm-hmm.
What's the best path for friends and family?
That's a really good question, because I think, we're a lot swimming upstream against cultural norms, but support is really important. And withdrawing love, if you will, or support from a person who's using drugs or alcohol is a decision that affects them greatly. So there are, I think, every person has to take care of herself or himself or themselves. You have to take care of yourself. And so if you're being harmed by someone's substance use, you may have to draw some really tight boundaries there. But I think that is different than just sort of disappearing that person entirely from the landscape of your life, right? So there are ways to be supportive. You can send people a URL, for example. You can give them a ride to a treatment. You can remind them if they relapse, that relapse is common, and remind yourself, and then ask them if they would like your help to navigate into treatment, right? And I think that one of the things that I find challenging in working with the community or families around is that people get angry when a person develops a substance use disorder, and they hold on to that anger for a long time, and we kind of collectively get angry, right? This is really sad. People with substance use disorders need empathy, right? It's not so much that they need our anger. We may be upset or disappointed, but when somebody develops another chronic illness, it's very rare that our reaction would be anger, right? Or distancing ourselves. We would encourage them to get help. We would not stop doing that. We would help them get help. And so those are some of, I think, the kind of mental shifts or cultural shifts that we collectively need to support and talk about. I don't know, Scott, if you'd add to that.
Yeah, I think that it's kind of a two-pronged thing. People are very reluctant often to engage in conversation with people that they care about, that they might suspect have something going on with them. And the symptoms that are associated with opioid use disorder can look like there's a lot of overlap with other kinds of problems. And so it's not always easy to figure that out. And the way you figure it out is really by talking with people. And often you'll get a pretty negative response initially, but that's not a reason to not talk. One of the real issues around people not getting better is that they wait way too long before they get any help for the problem. Average length of time somebody's been using routinely before they enter treatment is 5 to 6 years. That's a long time to be using opioids on a routine basis. You get very involved. You're going to have 6 of those symptoms after 5 years usually. So you're going to be in a severe opioid use pattern before anybody even realizes that there is a problem. And some of that's just a matter of not asking the questions that you might have or that you might have suspected before. The other thing that I would keep in the back of my head when I'm trying to talk to somebody that I care about is it's exceedingly rare that a person becomes opioid dependent on purpose, right? So they recreationally use and it feels really good and they start to do it more and more. Very rarely do they understand just how much danger they're in and how quickly this progresses to a point where they lose control of it. And then by the time they lose control of it, it's very hard for them to own it or to talk about it with other people. And it's often years before they will actually acknowledge that they have a problem to the point where they will enter treatment. And what we do know is that the earlier you enter, the better outcome you're going to have down the road.
And it's all kind of wrapped together, right? Around shame, self-stigma, shame. I don't want to tell anybody. Even if they ask me, I'm going to deny it because that's really not me. I'm going to fix it by myself. I mean, there's just a lot of, it's all kind of wrapped together around our cultural norms and some of the mythologies that we hold around substance use disorders. I think, Allie, you were trying to say something.
Yeah, I was just going to ask how businesses and organizations can advocate, I guess, from like an employer standpoint, things that they can do if they might see an individual or individuals who may have a problem and are concerned. Like, what's the best approach to take to helping an individual?
I think encouraging people to be evaluated. So a lot of businesses or organizations have employee assistance programs, right? Or you can send somebody to a place like APT Foundation just to be evaluated. And doing that in a way that is non-judgmental can be really helpful, right? So you see from a workplace perspective, we've noticed that X, Y, and Z is affecting your work. Have you had that checked out? Here's a way that you could do that, right? So really encouraging people to be evaluated is helpful. The other thing I think in the current, in our current circumstances as a country is that we should all have Narcan around, right? Businesses should have Narcan. People are dying. More than 100,000 people died in 2021 of opioid overdose, and almost everyone cannot die if we use Narcan in a timely enough way, right? I mean, so there are a couple of things, but really treating the person who's your employee in that particular question, Allie, as a valuable resource to your organization, pointing out what might be getting in the way of their successful work performance and offering them a solution, or at least an option to be evaluated, right? And see if there's something you can do.
Would you give that same advice to those who are working in schools where it's not necessarily, it might not be that the students are at the point where they have a substance use disorder or using regularly, but they might come into contact with laced drugs that might include fentanyl and other things. And, you know, you as a educator might notice that they're participating or talking about certain things. Would you give the same advice to those people or any different advice?
I think evaluation is always useful. I do think, though, that you're asking a slightly different question, right? One of the things that I think is really important is for educators or people who come into contact with other people, whether that be in, you know, a high school or a college environment, really know some facts about drug use, and that kind of information gets passed on to all of us. Right. I remember when my children were high school age children, they really didn't know the difference between various kinds of drugs. Right. They're not all equal. And really telling people straight up information, such as you just alluded to, that these days a lot of drugs that you might use are laced with fentanyl, and you may be unaware of that. Fentanyl is a very powerful opioid that can really kill you. And, you know, we've seen patients with about 30% of our patients who have tested positive for fentanyl didn't know that they were using it. So this is a new phenomenon here in our part of the world. And that includes people who might be smoking marijuana, for example, or using a stimulant like cocaine. They're not on purpose using an opioid. And this makes its way to student environments as well, where experimentation with drugs and alcohol is relatively common among students.
We have another question that came in that's a different variation in some ways on some things we've touched on, but what do you tell families that have been dealing with this for years with a family member?
Well, I think, as I said, it can be really challenging to have somebody in your orbit who, you know, isn't taking care of themselves or is perhaps causing harm to other members of the family. I think the family person, himself, you need to get support. Right? There are ways for you to be able to be supported as well, with or without the person in your family who's using. But I have plenty of experience in my own family with substance use issues. And I guess one of the things I would say is that the long-term nature of this is an indication of how chronic these illnesses really are, and making sure that you just keep putting in the way of your family member an option, whether that's a website or something like that, where they one day may be interested in changing their course. But again, you need to get support and help for yourself as well. It can be a long road for people, whatever chronic illness someone that they care about has.
Reframing it as a marathon, really, rather than a sprint or a
Absolutely.
Yeah.
The other thing that conversation I often have with people is they really will have a significant amount of discouragement, because often if a family has been dealing with this for years, people have already had some treatment experiences. And because it didn't go well before, doesn't mean that there couldn't be a way that it would go well in the future. So there's just different pathways. There isn't any one way to treat this disorder that's guaranteed to be successful. And also, as somebody goes through the arc of their addictive world, they're at different places at different times. So just because somebody was at a place one time doesn't mean that they won't be at a different one another one. And I think what Lynn is suggesting is that it isn't that you want to open yourself up and let somebody come in and just make chaos out of your life, which is what can happen. But on the other hand, I would keep an eye out for, is there something now that looks like there might be an opportunity here for this to move in a better direction? And be open to that idea and support that idea. But you can't do it for the person. They're going to have their own trajectory that they're going to take. But it's going to have its ups and downs. There's going to be times when there's no way you're going to be able to impact it. And then there's going to be others where you can see that there might be an opportunity here to do something. And every time somebody enters a treatment episode and they do well for a while, it's predictive of doing better in another one down the road. Like every time you have a success, you can build on that success going forward, even though there may be non-success in between. If you see what I mean. So I think it's important to take care, like you need to take care of yourself. You can't just open your world up and let people in and have their way with anything that they want to do that's so chaotic that you can see that it's going to do damage to you. But on the other hand, you can keep your eyes open and see if there's going to be something there this time that might be helpful, and to really not give up on it, because most people, a significant number of people do get better from this disorder. It's not a death sentence. There are people who do recover. In fact, more recover than don't, actually.
That's hopeful, and that's a good, I guess, to think about. Do you want to talk about any other topics you're going to bring up in the future for these community forums as we wrap up here today?
Sure. Yeah. Thank you for those of you who were able to spend some time with us today. We really appreciate it. We are very committed to using research and outcomes of research in our work to make recovery more possible for people and to make more people able to enter recovery. Really shout out to a couple of the APT Foundation team members that are here. I can see you. My thanks for showing up. And I would say we have a couple of topics upcoming. One of them is a seminar on dealing with the social determinants of health, how they interact with substance use disorders, and what we might do to understand that better and try and mitigate some of those impacts. Another being the co-management of opioid use disorder and chronic pain conditions. So Scott alluded to that, but some people start this pathway of becoming opioid use disordered by really taking a legally prescribed medication. So there is a lot of overlap between chronic pain and opioid use disorder, and co-treating those two chronic conditions is a specialty, and we are going to have a focus on that as well. Thanks so much, everyone.